All right. I will try to keep an eye on it. Understand why it's doing what it's doing, but Tim is in a meeting. Tim. So he asked me to take the first. It's supposed to be first hour, but I fidgeted with this for longer. Terry and David, I see you online. Again, if you see my lips moving and you can't hear, let me know. Getting you both in on the roster. Both of you have missed muffins this morning. More breath.
Because did he mess up? No.
Just because? Yeah. Oh. All right, so we're going to start with post-resuscitation. This is Tim's slideshow. So I'm sure that he's got a lot more to say about it than what I will. We're just going to go through it. If we have some time, I've got another slideshow, something that's a little bit more interesting, I'm sure, as opposed to post-ROSC, because we generally know, I mean, us as practitioners have been doing this for a while, so we generally know how to handle post-resuscitation. The next slide, kind of hard to. This is our ACLS algorithm. Of course, you're running a code. So you have return of spontaneous circulation, or ROSC. You optimize ventilation and oxygenation. Maintain a saturation that says 92 to 98%. Seems like the farther we get into EMS, the lower the yeah. And we were talking yesterday about what Rhonda had presented to us on the first day about COPDers. 89, 90% isn't a true emergency anymore if they're maintaining. And that goes along with the permissive hypotension, permissive vital signs that are lower than typical, your atypical patient, COPD or CHF, that sort of thing, because you don't want to overload them. So if they're maintaining, even at post-ROSC. Advanced airway and waveform CAPNO, avoid hyperventilation, maintain a systolic blood pressure of 90 or above. IVIO bolus, vasopressors. So I seen an interesting article talking about, and it was from Jim, IV versus IO access first. Having a better success rate with IOs as opposed to, it is quicker. It is quicker. And it gets, my thought process is it gets to the cells quicker. I mean, you're going right to the source.
I usually, if I look and I don't see nothing wrong with that, IO.
Yeah. I'm lazy. If it's a code and I know that there's not much availability there, I go straight to IO. I want to practice it too. I mean, I'm pretty proficient in IVs, so I want to go the route that I'm not as proficient, especially if it's going to be practice. Let's just be honest. Yeah. Yeah. All right. So find and treat all reversible causes, your H's and T's. Do we remember our H? What are they? Okay. Cardiac tamponade. Mm-hmm. 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 So something that we don't typically have bleeds on our
Yes.
post ROSC.
Oh,
Yeah, post.
I've not had those.
It's your ACLS.
No, like. I haven't had ROSC in the truck.
Oh, yeah. Yes, we have. You and I, he come back a few times.
Well, we've got time to do it. So,
Just trying to keep him alive. Mechanical circulatory support is required. So how do you maintain or how do you facilitate what we need to in a cardiac emergency if it's post ROSC and patient's intubated? Like if there's a true STEMI going on and your post ROSC, your patient is intubated, they're incapacitated. How do you work a STEMI?
Yeah.
Vent. Okay. Okay.
And what else you ask?
Mm-hmm.
Patient meds.
Okay. What kind of meds? So we can't give aspirin, can't give nitro. Pads. Okay. Morphine. Okay. You can if there's an allergy to it. And if you remember, the statement was you can't get fentanyl in a cardiac arrest. If you remember a while back when we had a certain Medicare that had a tendency of getting frazzled, they had not responded to a call because they were out of morphine. And Tim said fentanyl was appropriate in that aspect.
Yes, I remember that.
Yep. So you can use it as a backup. Yep. Basinger mentioned mechanical circulatory support. So that would be fluids, right?
Mm-hmm.
Would we consider a vasopressor?
Or depends on blood pressure.
Okay. Anything else? Lasix, possibly.
Depends. I mean, why would you get licensed in a cardiac arrest or
Hypertension,
a
fluid overload to begin with.
They gotta have time though between.
Depends on where it's at. I mean, if we're running to
You know, Agnes or somewhere, we'll come here or going back.
Baxter, yeah.
Yeah.
And if you have post ROSC and you have a viable rhythm, you're not going to stop here. I mean,
No.
you're going to go straight
No.
because that patient's going to have to go to cath lab. Oops.
Hey, you're 20 miles closer.
Yeah. So this next one is, do they follow commands? No. Comatose. Obtain a brain CT, which we're not going to do that. This is what they're going to do once they get to the hospital. EKG monitoring and other critical care management. If they're awake, critical care management. Your ventilation and oxygenation down at the very bottom. We all have poor eyesight and cannot see.
I know. So hard trying to see
Can you see that?
I can see that. I just can't see that close.
There you go. That's better.
All right, so avoid excessive ventilation. Start at 10 breaths, which scares me because less than 8, which they're already intubated, but that just don't seem viable. I mean, 12 to 20.
Oh. Breathe in, breathe.
Titrate your Petco. Maintain your oxygen of 92 to 98. Normal saline or LR 1 to 2 liters. I don't know if I necessarily agree with that. So again, with the permissive hypotension. Epi infusion, we didn't mention that. Dopamine and your norepi, which your norepi, we don't necessarily. I'm gonna check my messages real quick. Got screen, no audio. Yeah. Well, I'm a little unstable.
You're like, we are unstable. What are you talking about?
Okay, now she has both. Okay, good. All right, thank you. Thank you for that. All right, so This is a lethal cardiac rhythm. What is it? Mm-hmm. That's what it used to be. ACLS, that used to be fine B-fib.
Very fine.
Very fine. That's me kicking the cot on accident, is what that is. Shock it! All right. Another lethal. What is that? Shayna says sinus Brady. Anybody else?
Oh, that's no good. That's really going down my Creek Road.
Soon. Very soon.
VTAC.
VTAC. All right. What are we going to do for VTAC? Okay. All right. Anything else?
Well, are they awake or not awake?
Or post ROSC?
Oh, we're still post rock.
Yeah. Are we going to consider, are we stable or unstable? Okay, so we're going to go chemical or electrical. Okay, so we're going to shock. How many joules?
Well, it depends. Well, so after post rock, do we restart over with our drills or do we automatically go back to max at 360?
I would start out with your lowest dose.
Again?
Yes.
Like recycle. Okay.
Yeah. Because you had a rhythm change, right?
Yeah. But I mean, before post rock, do we shock them before post rock? Or was it automatically if we got?
So let's set up the scene. We're going to assume we got on scene, our patient was in a systole. Of course, we're not going to shock a systole. So we come into this rhythm en route after we give chemical. So we would start out with our lowest dose. Yes. All right. What is this? We're going to treat it any differently? Okay. Okay. This one's easy because, you know, it's there.
VFib.
VFib. Any different? What is this one?
PDA.
Okay. How are we going to treat it? Anything else? Sorry.
Am I the only one in here?
So PEA is what?
It's kind of
Yeah. So we're going to treat it as what? Okay. So what do we do for a systole? Okay. We shock for a systole if it's witnessed.
But we're post rock.
Yeah, we're post ROSC.
So it's just epinephrine. Then are we using lidocaine or is that the
Can you use lidocaine? Okay. Do we have amiodarone?
We used to.
Yeah. Do we have it on the truck right now? Okay. So what are we going to do? Lidocaine. Okay. All right. Well, that's good because that means you're learning.
No, like trouble. And the only one answering. Let them mute their mics and start talking.
So what is this? Idioventricular. Okay. What kind of idioventricular rhythm? Okay. So we have F40.
Well, there's no P waves.
Okay, works for me. Honey,
No, I know.
I can
No,
do.
I'm just talking out loud. So there's no P waves. So
Okay.
it's gonna be a different.
What does that T wave tell us? We went over H's and T's. Electrolyte imbalance?
Yeah.
Fluids. Okay.
first.
Mm-hmm. Shannon has a deer in the headlights. Look, we're gonna move on.
So what is it?
I would say.
It could be a junctional.
So what do your rhythms with no P waves?
Is it gonna be junctional or
It's gonna be a block, right?
no?
No?
Your
But-
blocks have-
You have them that drop.
Yeah, but they all have P waves,
Okay.
so that's not a block.
So what would you consider it?
Junctional.
Okay. There's no underlying rhythm?
Slow.
We'll come back to that.
Oh no, you can't just leave me hanging. Oh, you are gonna leave me hanging. Jesus.
So what is that?
Oh, that's a block.
That's a type 2.
Why is it a type 2?
It's got the, what is it called?
Yeah, it's the
Going.
no.
Yeah,
it's
it
a-
is. Count your squares.
No, but you don't drop a beat. That's all it's a second degree type 2 block.
Yeah,
Second degree type 1 winky block. That's the
no, but it's what I was trying to think of.
oh, winky block is going.
Yeah.
Mhm.
That's not that.
No,
That's a section. That's a number 2.
Okay. Mobit's type 2? Okay. David, I'm watching the group chat. So Terry and David, I can see your replies. David says complete block. Is that on the last one? You're saying complete block?
No, it's not a third degree block. It's the gap your 2 block. Back to this one.
We're back to this one. And I'm just saying that because David replied, and I think that's one because there's a lag.
Oh,
So I'm assuming that's the one that he's. If you think about it, I mean, you have your main components is your SA and your AV node, right? Atrial, ventricle. So if you don't have a P wave, what is being blocked? What is being overrode?
you're a thing.
Okay, so it's going straight to the AV, right? So you're not going to have a P wave. So it's block.
Accelerated junctional
Block. That's what I would say. Yeah,
block.
an accelerated junctional block. It's junctional, I agree, but it's also a block.
Okay.
Yes? No?
Yep.
David's still typing.
Okay.
Oh, you talk about the other one. Well, I don't know. Do you consider that a complete block? Because we have P waves. He says P waves march off, but don't match the QRS.
Yeah, but your P waves march.
So we're going to do a little Googling here. I'll be the first to say that cardiac is not, even though I'm an ACLS instructor, I can do the basic rhythms.
Oh, I guess it would be a complete heart block.
Which one?
That last one.
The one with no P waves?
Another one with P waves.
With P waves. They are independent of each other.
Right.
Hey,
should be over here.
okay, so this is saying an accelerated junctional rhythm. If you see that second one there.
Is post-cross the class that just happened?
We're still on.
We're still on it.
I have this open.
Okay.
We'll discuss that more.
Let's see what she thinks it is, the one before that.
Allison just walked into the room.
What do you think that was? It even. Okay.
Okay.
Well, yeah, I'm gonna stick with it.
Is it a block or not a block?
For the city of Instructor,
Mm-hmm.
I don't remember that you can see whether or not you have a block. I was right. I was like, because those ain't blocks, like those ain't considered blocks. It's just like an diagonal mark. I've never considered them a block.
This is what I'm looking. That's what I'm considering right there.
But those are PVCs, but those are still not. It's still not considered a block.
Okay. We'll get the master in here when he comes in. We'll discuss that since that's in his.
Really like that dress. It was really
Thank
cute.
you. Got a lot of compliments on this dress. Just ignore the socks. My feet were hurting. So, all right. So we discussed this one, and David went pretty in depth talking about this. We'll see if we agree. B waves march off, but don't match the QRS. They are independent of each other. Looks like a ventricular scape, not a block. That was on the last one. All right. What is this?
SBET or
Okay. All right. So what are we going to do for this? We're in post ROSC.
oh, post ROSC.
Yes. All right.
Well, if it's SBT, we can do it in a
Okay.
but then it gets post ROSC.
Are you going to treat it differently?
Depends if they're stable or not stable.
Are they stable if they're post ROSC?
I mean, they might be presenting stable for vital side.
Yeah, well, what's the blood pressure? I mean,
Yeah.
Throw one out there.
Well, if it's 70 over 30, I'm not doing it.
yeah.
290 over 210.
Okay.
That's mine all day long.
So let's debate this. So we got 70 over what?
I said 70 over 30.
Over 30. Okay. So what are we going to do for that? Fluids? Anything else? Okay.
Well,
So
I think that's pads on, it's less of a space.
okay. All right.
Honestly, yeah.
So let's do the opposite of that. We have Basinger's blood pressure, which was
290 over 210.
how are we going to treat that any differently?
You heard what?
Okay. Is that right?
No, we wouldn't have done it.
I mean,
You shot
You can
my
maybe
flat line, that blood pressure.
cardio work.
But you still wouldn't shop them.
It wouldn't just be a,
Huh?
it wouldn't be a random. It would be, you'd
You'd
have
have
to
to be
sync it.
synchronized.
Yeah, that's what I'm saying. Yeah. Synchronized cardio work.
Okay. So how are we going to do that?
Oh, I said that backwards for the other one. So pacing is when they're bradycardic.
Mhm.
And
Synchronized.
cardioversion is when they are.
Mhm.
Yes, that's
Good.
synchronized cardio work.
Good. Hoping you'd catch it.
Excellent.
What are you eating?
Yeah.
I made you muffins.
You need some protein. Don't go with the carbs.
Probably. Oh.
Make a sandwich.
Hey,
What's too big? It is not, those are more stuff.
do we know why his blood pressure's so high? Like, what's his pupils look like? Are we looking at a brain bleed? Like,
We are, what did we say? STEMI? Active STEMI?
Oh, this one's too, Sydney?
They're all gonna be. sandwich.
We're just going to keep it simple. It's the same patient rolling through all of these rhythms
Well, how do we know if it's a stimmy if it's looking like this?
because we did our 12 lead
Wait,
and
this
we
is
know
the
it's a
same
STEMI.
patient?
Yeah, we're just
Why
gonna.
have we killed him for his marriage?
So we went to PEA, we went to systole.
Yeah.
Poor Jimmy.
That one's weird, dude.
It's the most. So we also said that we're in Agnes and we're headed to Baxter. with our patient.
Oh, okay.
So 'cause initially we had a stable order.
Oh, we did.
Yes. All right. Next.
Lord,
So explain it to me.
you were too young to have known Dr. Buffett.
Oh, but I heard stories.
I know Bufford.
This would have been one of his. Oh, just go ahead and do it. You know what you're doing.
Good morning.
Hey,
What makes it reentry?
Huh?
The
It's AFib with RVR, right?
yes.
rate.
The rate? What's the rate?
$210.
It could be anywhere from 70 to 200.
Okay.
I like it.
No, sir.
Not really. I'm seeing bradycardia. I saw one over here. Very nice.
No, not so much.
Bradycardia? Well, how are we going to treat it?
Pillow therapy.
Atropine and what? Or pacing.
Well,
Okay.
it depends. They're unstable because it's post rock. So let's just go to pacing.
I like it.
We're going to pacing.
Okay.
Or I'm doing this one week.
How many joules? What does our patient weigh? Throw it away.
100 kilograms.
975.
Pacing, that's where you
Just do capture.
you're capturing, so it's gonna be like low joules. It's gonna be like in around 40 or something.
Okay.
Because
Okay.
the cardio version, you would start at your 100 and then 200.
Yeah. And so when you're pacing, it goes off by milliamps and capturing is 70. Start there.
Okay. So weight's not valid?
You should probably consider weight.
Yeah, if you're doing dosage, I don't know if it's chemical, but
Are we going to do anything to maintain?
What was our blood pressure?
yeah, I mean, if it's low, then we can get.
So let's stick with the two blood pressures. What's the difference between the two? 70 over 30 and 210 over 170? Is that what you said?
If not low blood pressure, we'll do an AVO.
Okay. What vaso?
Dopamine.
Okay. And hyper?
What do you want to do first?
Okay.
Again, I would be looking for, but I don't believe that blood pressure would match the heart rate, so I would be very, very confused.
I would do manual.
A manual?
Even the blood pressure.
Okay.
Yeah.
All right.
And what do you know? It's actually only 100 over 50.
Oh, that makes sense.
So we're given our vasopressor.
Mhm.
What is our dosage?
2 to 20 micrograms.
I am impressed. I am impressed. So 400-pound patient. Tell me what?
I do not give my screen's black. I will be using my calculator on the truck, so I'm not gonna mess this dosage up.
I'll do the high end if you want to low end.
I'll do the in between.
How much was the patient? 450?
450. Holy cow.
How much did you say the patient was?
I said 450.
So are we doing 450 patient wise?
Sure.
Okay.
That's 9% of them.
Oh, so it's 400 pounds.
I thought they were they 400 or 450?
Y'all, I don't
We'll
care.
just do your number, what you
Okay.
want.
He was a 400-pound patient, so.
With the
I got one
with the Lucas, it's 450.
181.
Uh,
You say you're gonna do the high end?
Yeah.
That's valid.
20 per
micrograms per kilogram.
I got 362 for the low end. Yeah, you got the high end.
Yeah.
So what is it?
3,636.
Is that micrograms?
That's micrograms.
Okay.
My low end was 362. That's for 2.
I don't know. I can't do it in my head.
And the freaking titrate that thing till his blood pressure starts looking good.
Okay.
I'm just gonna do.
I will cross drive.
Is that when you become an ambulance driver?
That's when we all become an
NASCAR kids
Come
can-
on, tag you're in.
All right.
Anybody comment on that? Anybody?
No,
Okay.
here's our next rhythm.
Yeah, that sounds
So we worked the paramedic magic, threw out some glitter and some sprinkles. And this is what we got.
Yep, we're doing good.
Both of you didn't get up front and drive.
Yep, good luck.
All right. Here's your 12 lead because you got a stable rhythm, right?
Oh, there's our.
There's your stimmy.
That's not.
What makes it a stimmy? Where's it at? I don't like that look.
Flowers.
Those are mine.
That's your enemy. Man. No, man, the math would hire me up. I know you're teaching the last time, but in real quick. Okay. Sorry.
You're fine. Good morning, Chris.
All right, we have new fuel cards. Don't take any of the other fuel cards that we have to put off yet. Because these originally did not work, but they did now supposed to. Okay. You have two trucks, obviously, at Mammoth. And then two trucks here. Okay. Don't die.
We're due.
Just, here's the thing. You have to punch in a code when you use this, and the code is very simple. It's your EMT number with a 0 in front of it. As long as Baxter pays the bills, that's what we're. Okay, that's why they didn't work at first, and then James got that corrected. I'm told, okay? Okay. Yes. Don't take any of the other cards off yet. Don't use the other fuel cards if this one works. I don't think they're gonna want us to charge a quick serve anymore. That's my understanding. If the card didn't work, charge here. So that's for vehicles.
So West Plains for fuel.
That should, the Murphy should work. He said that it works most everywhere, not just Murphy State.
Okay.
No work at Casey's.
Okay.
Oh, okay, so we're due.
66.
So we're always going to.
Yeah.
That's what I was told.
Okay.
I will do that just because. I'm sorry about that. But there's the other thing, I want to door, probably nobody would be happy about. But you understand, I have no control over most stuff. Hardly anything. Yeah. Okay.
Yeah.
They're going to,
We want this on
move our supply room.
Oh.
They're gonna move the supply room to your EMT office. Our EMT office. So everything will come out of the EMT office. All the supplies for EMS will be in there along with linens. We will no longer use Fulton County linens. We will only use the linens through the EMT office.
Okay.
Now, that doesn't mean Mammoth doesn't keep a power supply there also. You will. But the main supply will be here. And the office is gonna move down to where Frankie, well, you know where Laura's office used to be?
Right over here.
It'll be the one next to it. That will be your EMT office,
Next to the
So
chapel.
it's next to the chapel.
next to the chapel.
We'll all be praying for you.
So that's the most of it that I recall it though. It's
Too bad.
probably gonna, it's not too bad. It's gonna be a little inconvenient for a while.
Way they're talking, don't keep the meds where they're keeping it now. And she wants a list of everything
The meds, they're kept at the pharmacy.
up there in the ER by yours, where the Omni cell.
Oh, you're talking about the narcotics?
They're gonna try to figure out how to do it. That's what we're gonna try to do.
Good morning, Mike.
That's gonna be their problem.
So
But everything else will be done.
when we bring a patient in, we don't change our linens down there on the truck anymore.
Okay.
We come down here and get linens, then go back down there and change. Thursday.
And your used linens will go into the container there because they have to go back to Baxter.
Okay.
The reason why is right now White River is doing a lot.
Yes, sir.
And eventually, my understanding is that Baxter's gonna be doing a lot.
Okay.
But that's, I'm tossing it so much that I don't know what's right, what's wrong.
The blueberry's good.
Blueberries are awesome.
That was actually a big story.
But, anyway,
I cooked. Everybody take advantage.
any questions? We need to put out a, I guess, in text about fuel cards, how they work. Surprisingly, I've been working with some people, EMTs, did not know their EMTs. So nobody here has.
Well, that would be, the only one that would be,
Not me, I don't have. four digits.
oh,
He has a 3.
Well, I had a lapse from the military to civilian about 2 plus.
I had a
Five
4-digit.
digit. Huh?
I had a 4-digit number starting out.
What if it's only going to be a 5-digit?
Everybody's EMT number is 5
It's 5.
digits, but you have a 0 for that.
6 digit 0.
So the pin
so
is
mine would
6
be
numbers?
0333732. And then I mean, at Baxter, they ask you to put in your mileage, because it has a little deal. You slide that in and it says it wants a truck mileage, let's type that in, then your number before it leaves unless you fuel up. But I don't know how that.
It may not.
Do we still use the truck number for PIN number or just our EMT number? Okay, okay, cool.
Don't forget it. With your dementia.
Did that make sense on the decal number thing that I sent? That y'all sent?
The decal number. I didn't
Decal
get
number
that.
on trucks.
For our runs.
Use the number on 3 and the number on 2.
For now,
So 2103.
further notes.
I've emailed them in, she has a card, so we'll see.
That's on 2 numbers.
So we're in a debate. Are we done?
Done.
Okay. All right.
Whoa.
Don't
time
leave.
out.
Not real.
I admitted I can do ACLS because it's basic rhythms. This rhythm is not a basic rhythm. One of the things in your slideshow.
I'm taking off the lecture.
Oh, okay. So which truck are we running on? We're running on the blue truck.
Y'all be careful.
What is that? And why is it what it is?
Rate's 40, probably a little closer to 50. That is an idioventricular rhythm.
Okay.
And the reason why is because you don't see any P waves. You could be mistaken and think it might be a 3rd degree, but it's not. And here's what I'm saying, because that might throw you off.
Yeah.
Thinking that's P wave, but you would have many more P waves than you have QRS complexes.
Okay.
Okay. So that's why that's an IVR.
All right. So the newest medic students got it. That's why.
Let me tell you something. You'll never know more. Now that's what I'm saying, as far as the book is concerned, as when you first graduated medical school. I promise you. I'm gonna get my coffee, but we'll be back.
Good job. Good job. Very proud.
I didn't say.
No, we were here. Oh, okay. What is the next one? What do they call the next
And
one?
I see Kurtov.
The
Logo.
block.
Well, he didn't say anything about that one. We didn't get to that one. You talking about that?
Yes.
When he comes back, we'll ask him about that. Let's go back to the 12 lead. Let's talk about it. Okay, well, hold on. This is your slideshow, so this is all your fault. What is
Sorry.
what is this one?
Oh, that's easy.
Okay.
Third-degree block.
All right.
But you wanna know why it is? I mean, other than just it is.
I love it. What do I do? Because it is.
Well,
It's because your
here's one.
QRS waves march out and your P waves march out.
Very good. But there's no association with the P wave and the
Right.
QRS.
Right.
They're divorced.
Yep.
Okay, if you wanna look at that way. Okay, so, but that's right, if you took calipers, you could walk off your, that is a P wave, by the way. And they would walk off and one's hitting in here. They're all gonna walk off, and so will your QRS complexes. Usually be about twice as many P waves. Could be more.
This is why I'm so glad that you're teaching.
Well, I'm not very good
EKG.
at much, but I do know where those pretty well. No expert.
So do you have
How many pronounce?
Calipers?
what?
Calipers? Is that what you were?
No, Tassad.
Torsades.
Tassad.
Is that the one you know?
Right.
Torsades? We've already went over Torsades.
Oh, did you?
Yeah,
Okay.
that's fine.
Since you went over Tassad, what do you use to treat it? If it's in mag sulfate. I learned that in ACLS the other day. Because the only time you use mag sulfate was not for Torsades. You actually use it, you push it. Only for which you have to dilute it. They asked me that question, I said, I'm not gonna lie to you, I don't know. I said, I've only had a regret in my career.
So how much do you dilute it?
They said 10 mils, I believe. And then you push it, it's not a rapid push, but I think it's over 10 minutes. You can help me.
Something like that.
10 mils
I'm
per
not
what?
ready For Torsades.
Great.
So 10 mils per what? How many is micrograms, milligrams?
It's 1 to 4 grams, all inclusive dosage.
I think it's 2 grams, I think is what they.
Probably so, but the all inclusive dosage is 1 to 4.
Yeah.
But you're probably right on that. I'm not disagreeing,
No,
I
yeah.
promise. That's not a med that is used very much in EMS. But that's something that I never really thought about because I'd never been asked that question.
Yep.
And it was one of the old, well, it's not as old as I am, but an old nurse. Said, well, here's how we did it. Thank you. Sorry.
No. This is supposed to be yours anyway.
I'll just get up there and do it if you want to sit down.
Please do.
All right. Our 12 lead.
Wow.
Where's it at?
It's a problem.
Mm-hmm.
We obviously got an ST elevation in 1.
And ABL.
We got depression in 3.
So you have a lateral
ADL,
and a
V2, V3,
Look what it's a screen.
probably V4 and 5, I think. And some people say, no, you don't. But you do here, obviously, in 2 and 3. AVL 1.
You have a
You
lateral.
got a shit
septal.
show. Yeah. Everybody
Lateral.
knows over Lisa L.
Or if you
That's
Yeah.
how we
have
all learn, right?
Titus.
We have like elevation all of them.
Oh, yeah, okay, yeah. That's the one you. Well, okay, on this particular one, since would this concern you?
We're post
Well,
Ross.
we're post Ross, but yeah, 30 concerning.
Okay, we got it. I don't know what the title of this one was. What, I walked in late. But they obviously have an ischemia, right? But they also had an infarct. So it is post-rock. I wish I missed that part of the class,
Yeah.
sorry. But yeah, this is let's say it's not post-rock, this is a problem.
Yeah. You're very irritated. That's
What
why.
would you do for that particular patient? Don't take them to PCI hospital.
Oh, yeah.
But let me ask you a question. Could you give nitroglycerin if they ever have a chest pain?
Well, it depends. I mean,
We're innovated.
What?
Well,
Not post-rock. I'm talking about, let's say.
Okay.
oh, in general, right
In
now,
general.
which is blood pressure.
Very good question. Blood pressure is 140 over 90.
Yes, I would do.
Okay. Would you get mad?
Yes.
Do they take aspirin? Are they taking aspirin?
Ask if they're taking it or how much they're taking it.
Okay, are they on blood pressure? They take Eliquis, Orvax, Daxi, whatever. And they had one other question, have they taken back or the last 24 hours?
We even did.
Don't always ask women too. That you're gonna think, what? Just trust.
They take it for pulmonary.
And Well, for that reason, others, because they think it increases blood flow somewhere, I'm gonna stop right there. But would you give this patient morphine?
I would if they were hurt.
Because, okay, their preload's good. You're not gonna slam them with 10,
No.
2 to 10, titrated with 2. Could you give them fentanyl? Why not? I'm sorry, this is your class.
No,
No, it's not.
it's yours.
Well, if morphine was unavailable, you could
You
get.
could, but it's not, doesn't have the
The
cardiac
quality as morphine.
properties as
Right.
does morphine.
Right.
So morphine, and I always thought this, and of course, got talked to Brad quite a bit.
Morphine's a better
And
choice.
yes, it is much better cardiac drug than it is.
If that's
Yeah,
all you
it's
have.
longer lasting. Fentanyl's pretty short duration. Fentanyl's a great drug. But I don't like narcotics personally, but I've had it. So, sorry, go ahead. Did you finish with all of it?
Pretty much.
Cardiac arrest too?
Yes.
Good. I don't have to do anything.
Or no, not cardiac arrest. No. I thought you meant in the slideshow. Yeah, we did that. So the last slide.
I'll ask you, how often do you put a patient on a monitor?
Every time. Pretty much.
Very good.
Every time.
Every time, unless you're taking them to the house
Yeah.
No.
or a psych patient.
I mean, I always put them on the monitor, no
If
matter
I'm-
what.
If I'm like,
Should.
take them to like the doctor's office or something,
Well-
I don't.
Or swing, you're using common sense, I don't like that.
You don't have common sense?
No, it's not common anymore, I thought I was the one that had it. But, yeah, not really.
Sassy
You're
this
right,
morning.
but unless they start having problems,
Right,
the swing betters know, but take them home, no.
okay,
The
good.
psych patients that are, I'm gonna kill myself, so I don't, this on camera.
Yeah, well, you're not on camera, but you're being recorded.
Okay, my name is Brad. So they probably don't,
Unless they've taken.
unless they've taken an
Medication.
overdose of some particular type of meds, etc. Is it gonna hurt to do it?
I don't know.
But most patients that you transport, in my opinion, should be on a 4 liter minimum. And most patients, if it's a true problem, need an IV.
Part of your swing, they say this is a cardiac wire, because we don't always get the full story of what picking up.
Well, it depends. I mean,
Some are on 4 leads when we get there.
that's fine. I mean, I have no problem with you doing that. But if someone's going for just a routine clinic visit,
Like tomorrow.
well, I mean, you're not gonna hurt. It's not gonna hurt. But bear in mind one thing, just because you don't need to check if anything's ALS emergency or non-emergency anymore. Okay, Baxter does that. But just because you have somebody on cardiac monitor does not mean it's an ALS run.
Okay.
At all.
IVs.
It does not mean it's an ALS run necessarily.
All right.
When you transport, now, let me back up. If you transport a patient that has an IV, yes, it is an ALS non-emergency. But just because for giggles you want to start an IV, it doesn't. It has to meet certain criteria to be an ALS run through Medicare.
What's the criteria?
I got pages, booklet about that thick if you want to see it.
All right.
And it changes yearly.
Okay.
So.
Of course.
But what I'm saying is I used to always, if you checked them, that was fine. If you didn't, that was fine. I would check them. But now you have experts, and I'm being honest, the two that do the billing coding are very good. So if you mark something, I'm not gonna mark it out. They may.
Yeah.
But anyway.
All right, so we're gonna go ahead and take a 10-minute break, and then we'll come back, and Tim will be up next.